to masquelet or to not masquelet? I wanted to say masquelet, but it is masquelet. So I'm going to spell it Masquelet. So that's what I say. To masquelet or to not masquelet. And if I'm pronouncing it wrong, forgive me. But that is the question. And for many limbs at risk, the answer could be life changing. So, when facing a massive bone deficit, defect, a chronic osteomyelitis, or a limb hanging in the balance, surgeons often face a difficult choice. Is there enough biology left to rebuild? Can we create new bone where no bone exists? So, today in Diabetic Foot Files in Salvage Saturday, we're going to be exploring one of the most innovative reconstructive techniques in modern limb salvage, and it's Masquelet technique. And from antibiotic cement spacers to mysterious induced membranes that act like a biological chamber for bone regeneration, we'll break down the science, the surgery, and its role in diabetic limb preservation. And so grab your scalpel, your curiosity, and your masculate. I mean, I just always associated it when I first learned about it with Shakespeare. Okay? So let's dive into it. So, who invented the Masquelet technique? So, the technique was developed by an amazing man named Alan Masquelet in the 1980s. So, that's quite recent. So, Masquelet, he was treating patients with massive bone loss, traumatic injuries, chronic osteomyelitis, failed fracture repairs. And traditional bone grafting often failed when these deficits became large, these defects. And he noticed something unusual. Whenever he used bone cement and it was placed in the area of the large defect, the bone formed this thin membrane layer around it. And instead of considering the membrane as a nuisance, he studied it. And this discovery was quite life changing when it comes to reconstructive surgery forever. So, see, curiosity did not kill the cat. It actually got the cat in the history books. So, the problem why these bone defects are so difficult. So, bone is a living organ. It requires blood supply, growth factors, stem cells, and mechanical stability. And when a bone is infected and is removed, there is a large void that remains. And imagine removing a metatarsal, which we often do, or a portion of the calcaneus, or even a segment of the tibia. The body cannot simply fill these large gaps with new bone. Instead, the body fills it with scar tissue or soft tissue collapse inward, or the bone healing just fails. And this is called critical size defect. And without reconstruction, the patient can face chronic infection, non union, as well as risking amputation. So, Masquelet is made in two stages. Stage one. Stage one, the first stage requires and begins with aggressive surgery. The surgeon removes the dead bone, the necrotic tissue, the biofilm, and the foreign material. And this is known as source control. That's what the doctors are talking about. Source control is a huge role when it comes to limb salvage and treating these diabetic foot ulcers. So let's say it's diabetic foot osteomyelitis. This means removing all the infected bone until there is healthy bleeding bone. And many surgeons describe this, as operating until the bone smiles back because they want healthy bleeding bone. Okay. Dead bone does not bleed. Okay. Nah, not really. So, what happens next? After debridement, what is left? A large cavity. And instead of placing a bone graft into this hostile environment, surgeons place antibiotic-loaded cement spacer. Most commonly, this bone cement spacer is polymethyl methacrylate. PMMA. And this spacer serves several purposes. One, it delivers antibiotics. It has high concentrations that are delivered directly to the surgical site because we're putting it in the surgical site. Two, it maintains the space, so it prevents the soft tissue from collapsing into the defect. Three, it controls the infection, so it creates this environment that is less favorable for bacterial growth. And four, it sets the stage for regeneration. So this is where the magic begins. So most commonly used antibiotics mixed into the PMMA, the polymethyl methacrylate bone cement, are chosen. So it's chosen because it's heat stable. So PMMA curing generates heat. It's available in powder form. I actually like to play with it. I mean, you know what I mean, not play with it, but like make the cement and like yeah, other things. Broad spectrum, and it's available to elute from the cement over time. So what are the common antibiotics? But it is really cool to do and like make it yourself sometimes. So most common antibiotics that we use for these bone cement is vancomycin. So the coverage is going to be MRSA. We know that covers MSSA, causes collagenase negative staphylococci, as well as enterococcus in variable situations. And this is probably the most common antibiotic added to diabetic foot and limb salvage cases already. Next is tobramycin. So tobramycin gives us coverage for our Pseudomonas, our Enterobacter, our Klebsiella, our Proteus, and other gram-negative organisms. So that's why it's often combined with vancomycin. Then sometimes gentamicin is covered in that as well. So gentamicin covers similar to gram-negative coverage as well as some gram-positive activities. But some commercial bone cements already contain gentamicin, so that's awesome. So what is the common combination of the antibiotics in the bone cement? These antibiotic bone cement, PMMA. So the classic limb salvage mixture is 2 to 4 grams of vancomycin and 2.4 to 3.6 grams of tobramycin. And then mixed into this 40-gram batch of PMMA cement. Why both? Because vancomycin covers the gram-positive coverage and tobramycin is the gram-negative coverage. And together, they work amazingly to cover most of our diabetic foot osteomyelitis pathogens because we know that they are always polymicrobial most of the time, okay? So why does the antibiotic work better in a combination? It actually does another thing. So adding those two antibiotics often increase elution. So the antibiotic particles create this microscopic pores in the cement, and more pores mean better antibiotic release, means higher local concentration of the antibiotic. This is called passive Porygon effect. So like we know that these the tobramycin plus the vancomycin covers many of these organisms, like I mentioned, Staphylococcus aureus, MRSA, Streptococci, Enterococci, Pseudomonas, Proteus, Klebsiella, and Enterobacter. So how high levels are the local antibiotic levels? So this is one of the biggest advantages to the PMMA spacers. Patients may only achieve an active serum vancomycin level of 15 to 20 micrograms per milliliter, but around the spacer, if we're talking about just localized to the spacer, local concentrations could be hundreds to thousands times higher than systemic levels could ever reach. And these concentrations can exceed what safely can never be given intravenously to a patient and help penetrate the bacterial biofilm. But there are some limitations to the PMMA. So PMMA is not biodegradable. So that's where we come into the second stage, right? So after the first stage of the Masquelet procedure, so let's say we infected bone is removed, the antibiotic spacer is placed and inserted. The membrane takes about 4 to 8 weeks to form, and the spacer is removed, and then you replace that area with the membrane with a bone graft. The bone graft is placed inside the induced membrane, and the spacer itself is usually not intended to remain permanently in a classic Masquelet reconstruction. Okay, so for our diabetic limb salvage, the workhorse of the antibiotic combination remains vancomycin and tobramycin because it provides that broad spectrum coverage against the gram-positive as well as the gram-negative pathogens that most frequently we encounter in diabetic osteomyelitis, while maintaining excellent heat stability as well as elution characteristics with PMMA cement. So let's talk about the induced membrane. So within days, the body recognizes the antibiotic cement as a foreign body, pretty much. And there is a membrane that develops around it. At first glance, it seems like a normal foreign body reaction, but it is much more. Researchers discovered that this membrane is biologically active. It produces a vascular endothelial growth factor, VEGF, transforming growth factor beta, bone morphogenic proteins, as well as other healing molecules. So, in essence, the body is building its own living bioreactor around the cement. So, why is the membrane so important? So, the membrane functions as a natural incubator. So, it creates new blood vessels. The membrane becomes highly vascular. And what does more blood flow mean? Means more oxygen, more nutrients, and better healing. Next thing the membrane does, it prevents bone graft resorption. So without the protection of this membrane layer, the bone graft usually can disappear before healing can occur, and the membrane protects the graft. Next is it concentrates the growth factors. The healing molecules become trapped within the membrane. As well as the membrane contains stem cells, so the mesenchymal stem cells help generate new bone as well. This transforms otherwise this hostile environment that it could be because of the deficit into a regenerative chamber. So in the induced membrane, unlike a typical foreign body reaction that leads to dense scar formation, a PMMA spacer induces formation of a highly vascular pseudosynovial membrane around the cement. And that takes approximately 4 to 8 weeks, and the membrane matures and becomes biologically active over time. And the membrane contains fibroblasts, mesenchymal cells, macrophages, endothelial cells, pericytes, okay, not parasites, pericytes, Pericte, and osteoprogenitor cells. And this membrane essentially becomes a living bioreactor for bone regeneration. So this happens in quite the membrane regeneration happens in phases. So phase one is the initial inflammatory phase, which is takes about 1 to 7 days. So immediately after the spacer is placed, the platelets are here, the fibrin clots form, the neutrophils arrive, and macrophages infiltrate. Macrophages release IL-1 beta, IL-6, TNF alpha, and TGF beta. And these cytokines recruit fibroblasts and endothelial cells, and this is similar to early wound healing. Phase two is angiogenesis. So week 1 to 4, it becomes interesting. So the macrophages and the fibroblasts begin producing the VEGF, the vascular endothelial growth factor, the fibroblast growth factor, as well as the platelet-derived growth factor. And these growth factors stimulate endothelial cell migration, capillary sprouting, as well as new vessel formation. And histological studies have shown that the induced membrane becomes densely vascularized, and that's what we want because the membrane pretty much starts functioning as a periosteum, kind of. Phase three, this happens between week 4 to 8, osteogenic signaling. And this is as the membrane matures, right? It begins producing the VEGF. So this promotes continued angiogenesis. It also creates bone morphogenic protein too. This stimulates the mesenchymal stem cells to become osteoblasts. It stimulates TGF beta. This stimulates the matrix production. It also has osteocalcin, and that is a marker of active bone formation, as well as type 1 collagen. Type 1 collagen forms the scaffold for mineralization. So when there is a cancellous bone graft that is later inserted, it enters the environment that is already rich with growth factors. So why is the membrane so important? It does four critical things. The membrane prevents bone graft reabsorption. So without the membrane, the osteoclast can rapidly destroy the graft material. The membrane, actually, this induced membrane protects the graft. It provides blood supply, so the new capillaries penetrate the graft. So without the blood supply, osteoblasts usually die and the bone graft fails. Three is it produces the growth factor. Like we said, it's very rich in the growth factor, VEGF, B and P2 and TGF beta. This helps stimulates the osteogenesis. And four, it creates a closed biological chamber. Think of it as a biological incubator surrounding the graft. So let's get to stage two of the Masquelet technique. So stage two is we're building new bones. So typically after 4 to 8 weeks, the surgeons return the patient to the operating room and the antibiotics cement spacer, bone cement spacer is carefully removed. So importantly, the membrane is preserved. Think of it as opening an egg without damaging the shell. The membrane cavity is then filled with most likely osteogenous bone graft. So it's usually harvested from your iliac crest or your tibia or your femur. And the autograft remains pretty much the gold standard. Why? Because it has the living cells, it has the growth factor, and it's a natural bone matrix. So what happens biologically after the graft placement? Osteogenesis, so the living bone cells create new bone. Osteoinduction, the growth factors recruit the stem cells. And osteoconduction, The graft provides a scaffold of bone formation, and the induced membrane supports all three of these processes, and this is why the technique works so well. So, how is it used in diabetic foot surgery? So, the Masquelet technique is increasingly used in chronic osteomyelitis, after infected bone removal, Charcot reconstruction, limb salvage, and other failed previous surgery. And when traditional reconstruction has not succeeded, the antibiotic and preserving limb length and function can be life changing. So, what happens in diabetes? We already know what happens. This is where the diabetic limb salvage becomes a little challenging. The hyperglycemia, we already know, affects every step of the membrane formation. So, impaired macrophage formation, macrophages become trapped in this chronic inflammatory state instead of transitioning from M1, which is the inflammatory, to M2 in diabetes, it does sometimes predominantly remain the M1, which is inflammatory, and that consequence would be mean more TNF alpha, more IL-6, and less tissue regeneration and reduce VEGF activity. So we already know diabetes does suppress effective angiogenesis. So even when there is VEGF produced, the endothelial cells will continue to respond poorly. The capillary sprouting will decrease, microvessels become dysfunctional, and the membranes become less vascular. Next is, we have to tackle also the advanced end stage glycation end products, right? The advanced glycation end products, the AGEs. So chronic hyperglycemia leads to advanced glycation end products, which will cross-link the collagen, stiffen the tissues, and increase oxidative stress. And the induced membrane becomes less flexible and less biologically active. Next is stem cell dysfunction. So the mesenchymal cell in this diabetic foot show, they get reduced proliferation, reduced osteoblast differentiation, and reduced BMP responsiveness. And the graft receives fewer bone forming cells. And what happens with the microvascular disease that we have to tackle in diabetic feet? So imagine a diabetic patient with tibial arterial disease, right? The membrane success depends heavily on the angiogenesis. However, the arterioles are narrowed, the capillaries density is reduced, and tissue oxygen tension is much lower. So the membrane develops in a relatively hypoxic environment. So while mild hypoxia stimulates VEGF, severe hypoxia overwhelms the system, and that could result in fewer capillaries, less oxygen delivery, less osteoblast activity, as well as delayed graft incorporation. So that's why you hear me always saying vascular, vascular, vascular. Revascularization plays a huge role. So in diabetic limb salvage, restoring the blood flow before or during the reconstruction can dramatically improve the membrane quality. More blood flow means better macrophage function, more endothelial recruitment, increased VEGF response, better oxygen delivery, better graft survival. And this is one reason why collaboration between podiatry, vascular, and orthopedics is so important, okay? So we always have to remember that. Like, I'm not just saying vascular for no good reason, okay? And we have to ask the question, does the induced membrane in diabetic patients produce lower concentrations of VEGF, P, BMP2 and TGF beta compared to non-diabetic patients? And can adjunctive therapy such as revascularization, topical oxygen, hyperbaric oxygen, stem cell therapy, and biologics help restore the membrane quality? Possibly, but they need to research that much more. But in often truth, this Masquelet technique is not often used when it comes to diabetic limb salvage because of the peripheral arterial disease, neuropathy, chronic inflammation, poor bone quality, and impaired healing capacity. Because why? Masquelet technique depends heavily on angiogenesis, osteogenesis, and adequate tissue coverage, soft tissue coverages. Okay? So, all three are usually compromised in diabetes. But, where have this been reported? There are small cases or case reports or small series that have described successful Masquelet technique in tibial defects after diabetic foot infections, calcaneal osteomyelitis, midfoot Charcot reconstruction, forefoot and resection defects, and limb salvage after transmetatarsal amputation failure. So the literature is quite promising, but there have yet to been large randomized trials, specifically in diabetic patients. Okay. So what makes this superior to traditional bone grafting? Traditional bone grafting bone places the bone directly into the defect, okay? And the problems include poor bone supply, poor blood supply, say bone supply, poor blood supply, poor infection, like infection and graft reabsorption. And the Masquelet technique prepares the environment first. So instead of planting the seeds in a desert soil, it makes sure that there is a fertile ground before they plant the bone in it. And the clinical outcome studies have demonstrated it has high rates of bone union, excellent infection control, successful reconstruction of large defects, and improved limb preservation. So any defects that are exceeding 10 centimeters have successfully been reconstructed with this technique. Okay. And in some other reports, even larger defects have healed. And like I said, what are some of the limitations of the Masquelet technique? The Masquelet technique is quite powerful, but not perfect. Challenges are it does require multiple surgeries, at least 2 are required. The treatment does span over months. Infection recurrence, especially if the debridement is not adequate, and graft availability. Large defects require large volumes of graft, okay? So I think the future of that, the Masquelet technique will definitely include stem cell enhanced graft, 3D printed scaffolds, synthetic bone substitutes, growth factor augmentations, and biological membranes, okay? But what are our clinical pearls at the end of this episode to understand about the Masquelet technique? The Masquelet technique is a two-stage reconstruction strategy. Stage one, you remove the infection and place the antibiotic cement spacer. The spacer induces this amazing induced membrane that is biologically active membrane. Stage two, you remove the spacer, you fill that and leave the membrane, the induced membrane, and you fill the membrane cavity with actual bone graft. And the induced membrane promotes organization, forgive me, and bone healing. And this is essentially quite valuable in osteomyelitis and limb salvage cases. So this technique has constructed some of the largest bone defects ever successfully treated. So, in closing, the Masquelet technique teaches us one of the most profound lessons in medicine. Sometimes healing isn't about forcing the body to regenerate, it's about creating the conditions that allow regeneration to happen naturally. And that membrane that was once dismissed as scar tissue turned out to be one of the most powerful tools in reconstruction. So, for our patients facing amputation because of infection, trauma, bone loss, this discovery can mean a second chance for helping them keep a limb. So I hope everybody loved this episode. This is Diabetic for Files. I'm Dr. G. This is where we investigate the science behind saving feet, preserving limbs, and restoring lives. And take care of your feet because they take care of you.